Good afternoon, everybody. Welcome to our uh, restart of HiPAM. Rukia, if you can let me start utilize my video, that'd be greatly appreciated.
Yes, give me 1 second. Sorry about that.
Okay, no worries.
Okay, should be good to go.
Awesome, thank you. Let me see who we have. Oh, Bobby, good to see you. Cynthia, thanks for joining. Yoonjung, Francis, as always, good to see you. James, nice to virtually meet everybody who's new. Dr. Berryman, Monique, Dr. Shiba, of course, Tom. So glad to see a lot of new names. Hopefully, it's not just because we're seeing a surge in cases that everybody's getting concerned. Obviously, I am, but the point of HiPAM is not just to. It seems like the timing was worked out. We came back just when COVID's surging. That was not our intent. For everybody who's new, we were going very consistently from last April, and the core members needed a break a couple months ago. So we've kind of worked on our mental health a little bit and ready to get going again. So with that, the next slide, please. Perfect. So, hopefully everybody's taking some time to watch the Olympics. We were, last when we left off, Japan was definitely trending down. We were hopeful that they were going to have a COVID free or even or very low risk of COVID during the Olympics. But as you can see, they're definitely surging. They're looking at potentially shutting down 3 adjacent prefectures surrounding the metropolitan area. So it's definitely worsening in Japan. Next slide. South Korea definitely was increasing. Hopefully they reach their peak and they'll come back down. But once again, the trend has been going up for both of these strong countries who led the initial effort last year. And of note, if you look at we're seeing that their vaccination status is increasing, their vaccination rates. However, it's still not at the level that Hawaii and the U.S. is as a whole. So that partially explains why they're increasing at a significant rate. Next slide. India, they had that massive surge. Thankfully they haven't had any additional wave yet, but we're going to continue to keep an eye, as that's kind of where the Delta variant originated. Next slide. So at a national overview, we were doing very well, trending down and then holding steady at what we were hoping and thinking was the new kind of baseline for the nation, understanding that once you dive a little deeper into specific states and counties, you're going to see variance of variation of disease activity based on vaccination levels. And we're seeing that play out in Hawaii, but unfortunately nationally as a whole, we are trending up, with recent data that I'll go over in the science highlights, contributing to the increase nationally. Next slide. Arizona, California, 2 of the 4 states that we always go over for our new participants of HiPAM, because we typically get a lot of travel to and from those states, both tourists and residents traveling there for work or leisure and returning back home. So seeing an uptake in both states. Next slide. And then Nevada and Texas. Again, we're seeing that trend mirror the national. And then, for Nevada, it's Las Vegas is there, the 9th island, and it's at least from what I've been seeing when I watch TV or listen to the radio, they've been really marketing return to Vegas hard for our Hawaii residents. So that's a high level of disease activity. Next slide. For Hawaii's overview, our test positivity rate, as you can see, unfortunately is trending up on on all counties. Kauai dropped down a little bit and is under that 3% threshold, which is good. Maui as well. But the big county, the county that is definitely surging more than the other ones is Hawaii County. And obviously the state overall is increasing in its percent positivity. Next slide. And then in terms of our overall vaccine administration, we've definitely slowed down. I think we may now be at 60% fully vaccinated. I can't quite remember the date, but I believe maybe July 4th or July 1st was that's when the lieutenant governor was expecting to hit 60%. Obviously, we're about 3 to 4 weeks beyond that time frame, and it doesn't look like where our rate is going to increase anytime soon. And that kind of ties into the presentation that Dr. Shiva will be giving a little bit in terms of impacts of varying levels of vaccination. In terms of forecasting, and Jim, I see your question. Is the best interpretation of a rising positivity rate as a need to increase testing? So I look at it as we need to look at, positivity rate provides context to just overall testing. But I think what's different now, and I'm glad we have Dr. Berryman to correct me if I'm wrong, and please do so, Janet. It's been a while, but because a substantial, 60% of our population is fully vaccinated, more so than not, the bulk of our tests are going to be amongst the unvaccinated. Therefore, a lot more of them are going to test positive for COVID than not, which is why, while our overall test numbers may be a little lower than last year, our positivity rate it is high. So it goes hand in hand. One is not more important than the other. You need both for context.
Thanks. I mean, I think that you have to look at positivity rate in the context of who you're testing and where. If you think that you're mostly testing the worried well and the low risk population and you have a high positivity rate, then that's a problem. If you think that your testing is well targeted toward where disease is spreading and you have a high positivity rate there, then you just need to continue doing what you're doing. So it really is a question of assessing how well matched your testing efforts are with where you hypothesize your disease spread is. So I don't think you can say that high positivity rate necessarily means you need to do more testing. You have to look at it's a little more complicated than that.
Correct. Yeah. Could concur, Janet. Thank you. Next slide. So unfortunately, our 2-week forecast is now having us trend upward, and factoring in the large the significant sustained disease activity the past 2 weeks of triple digits. The cases obviously will be forward looking, but the hospitalizations and the ICUs are reflective of the past 2 weeks activity, understanding that there is a lag from cases when someone becomes infected and becomes symptomatic to when they go to the hospitalization and then further into the ICU, which is why there's a little disconnect in terms of the intensity or that we see the steepness of the curves for the hospitalization and the ICUs. Next slide. And this slide for our new members is just the previous slide, just in a numerical format. Next slide, please. So for science highlights, some more sciencey than others. And right before I hopped on, I'm looking down on my phone, and I'll speak to this at the very end. But things constantly change with COVID. I don't need to tell anybody that. Everybody's aware with that. So with that, next slide, please. So yeah, 2 days ago now, CDC updated guidance for fully vaccinated individuals, now recommending that regardless of vaccinated status, so now mainly for vaccinated individuals, what's changing is they are recommending mask wearing indoors, especially if you have a weakened immune system or if you are living with someone who is unvaccinated, which is different than the previous mask guidance. And that's in line with unpublished data that they say they're going to publish tomorrow that points to the fact that Delta now, in addition to being more infectious, is also more likely to lead someone to the hospital. So next slide. And then they also published something on the same day, providing more guidance for communities, states, counties, for prevention strategies in the context of different community transmission levels. So, with this mass guidance, it's not just, okay, everybody needs to do it. It's based on where, depending if where you live has a substantial or high, at least a substantial, if not high, transmission level of one of two indicators. First indicator is the total number of new cases per 100,000 in the past 7 days. And the other is the percent positivity in the past 7 days. So one thing I want to point out is if you look at the DocD website, they do such a great job of data visualization and looking at different strata variables to get a better understanding of where the disease is hitting us hardest. But they present a metric, new daily cases per 100,000 in the past 7 days, and that's a little different than what the CDC is saying. So whatever number you see on the DocD website, I think the state overall is at 13.0 new cases per 100,000 in the past 7 days. Multiply that by 7, and that should be the number where you plug into this first indicator. So it's more semantics than it is the data itself. The data is in line. It's just how the data is presented in the context of this particular indicator. So I just wanted to bring that to everybody's attention. So when you look at the DOH DocD website and then you refer to this this guideline, you understand where the numbers are matching up. Next slide, please. And then finally, or not finally, the third science highlight is from CDC again, updated 2 days ago. But I think they're going to change it tomorrow. A lot of evidence points that fully vaccinated individuals are less likely to transmit COVID as a breakthrough case than unvaccinated individuals. And this is based on studies looking at the alpha variant and the original viral, the initial strain. However, and I'm going to wait until CDC releases data tomorrow. All signs point to the fact that Delta, if you're a breakthrough case with Delta and you're which means you're fully vaccinated, you actually are at an increased likelihood of infecting others, which is different than what we have seen with breakthrough cases of other variants. So more to follow for this particular highlight. Next slide. And then finally, we have our resident legal analyst here, but I bring this up because policy really has impacts on modeling and behavior and what happens writ large to our community. So DOJ published an opinion saying that federal law does not prohibit businesses, agencies from not mandating, a double negative. So federal law allows business agencies to mandate COVID vaccines. And so, right after that, the VA, one of the biggest federal agencies, started to require vaccinations for all of their healthcare providers. And then I believe it was yesterday or 2 days ago, Maui Memorial Hospital, the main hospital in Maui, is now requiring vaccinations for visitors. So you're starting to see more of a harder approach to kind of get vaccination rates up and to protect the vulnerable populations and the high-risk populations with regards to vaccines. So definitely look to the news tomorrow and see what CDC puts out for our next community highlight. We will make sure to highlight that. But if there's no questions, I'll hand it to Dr. Shiva. So a question, Jimmy posted, when will these slides be available? Rukia will post a link to where the slides are hung, Jimmy, and you can look at them at your leisure. Apologize if I went a little quickly. I want to make sure Dr. Shiva has enough time to share all of her great work with that her and her team have put together. And with that, I believe that's the last question. And thank you very much, Dr. Shiba, for presenting. For everybody who's new, she is a valuable member to not just HiPAM, but our state and our community with the work that she's done and her team has done. So with that, I'll let you take it away.
Hi, thank you, Thomas, and welcome back, everybody, for those community meeting on Thursday. It's very timely that the decision was to start today already a while ago. I'm going to share my screen, and I'm going to discuss a little bit some modeling for the Delta variant and a few other things, but I'd like to clarify for people that forgot, we haven't met for a while, so that if you ask me what is going to happen, then I can guarantee you that I don't know. And I think that's very important to keep that in mind. Now that we are looking back at what happened, we know some stuff, but looking into forecasting and looking at what is going to happen is very difficult, and we don't know because mitigation might change, the rule can change, there might be a new variant, so we have to take everything very cautiously. However, we make scenario, we make assumption, and then this we can share and try to understand what might happen under those cases. So first, I'd like to go very quickly over a little bit of the model that we have. I'm assuming everybody can see the models page. If not, just someone ping me. But so there are two types of model, and I'll go very quick. I will go to the Delta variant and some of the forecasting because I want to generate a discussion. So there are two types of epidemiological models. So there is the compartmental model, like the SEER model that is famously known, and then there are the agent-based models. So the difference is in terms for the EBM model, the compartmental model, the population is aggregated versus for agent-based model, you look at individual. And so we have looked at both models, and we have been wondering, is there a better model to use, or are different type of model going to give us different type of outcomes? So we have worked them side to side on the same type of data. So I'll just show you how, like, some advantages and inconvenience of different models. And what we've learned is that both models for modeling the pandemic here in Hawaii have been very useful to us. And it was not one against the other, it was understanding when to use one versus the other. So here is just the little schematic of the typical SEER model. And then we just broke it down into different categories, like the fact that we know for COVID, we knew quite quickly that you can be asymptomatic and typically for a length of 14 days and you could still transmit. That made it a little unique. So then we broke those compartments into subcompartment, but this is the schematic for the basic SEER model that we used at the very beginning of the pandemic, and it really helped to understand how to fit some of the parameters that are key, like the transition rate, etc. So that was a very important part. With a model like that, fairly easy, conceptually easy, computationally cheap, which was important. We could run a lot of simulation and try to fit early on some of the data and get an understanding on how the transmission rate would play in different settings, like when we do a lockdown or when we open everything, etc. So then, so like this is, I won't go into the details, but this is the main parameter that we were trying to understand in order to fit well the data that we were collecting as the pandemic was initiating at the beginning. So then what happened is that travelers came into the picture. That was October 15, they started release. So we included, there was a lot of question about the role of travelers and the tourists, especially at the beginning, but it ended up that the residents coming back into the community are the one that were creating some issue and bringing some cases back to the island and creating some surges like we saw on Kauai at the time of the implementation of the safe travel program. So we incorporated that into the model, and it just like got the compartment a little bit more complex. And then at the end of December, we had vaccine. So adding the vaccine in the compartmental model was difficult because you have 1 shot, 2 shot, then you have to make sure you have a compartment for everybody. Then they have different rates at which they get sick or not, at which they transmit, at which they impact the other community that are not vaccinated. So it became, so the schematic became a little more important. And here I'm just trying to show that this model, this compartmental model are good, but they become conceptually very difficult very quickly. Okay, they're very good to start, they're very good to optimize some rates to fit the model, but then when you start adding things as you move along into the pandemic, they're very hard to work with. So then we started looking at agent-based models. So those are when you just really, you go at a very granular level and you look at the individual. So the best way to look at it is you build a network of individuals, and then you try to understand the network, and you have attribute for every agent, which is the age, whether they're infected, diagnosed, and then conceptually, it's very easy to add attribute, right? Because then it's just, if suddenly you're like, okay, so now vaccinated or not, you just add a line into your agent and the attribute. However, the downside of those models is that they are computationally very heavy. Okay, so that means you need, like in Hawaii, we have a 1 million population overall, so it wasn't bad and we could work that. But if you start looking at California, then the computation become heavy, and you have to keep in mind, if you have those type of models, the agent-based, they're stochastic, you have probability. So you need to run about 15 to 20 simulation and average it in order to have a final result in the end. So it is really a trade-off. We used CovaSim that was developed by the Institute for Disease Modeling. And then it was really a trade-off between computational and conceptual complexity. But I wanted to show you mostly the following picture. In blue, you have the fits that we found using the compartmental model, the a little more complex SEER model that has travelers and vaccine. And then in green, you have the fits that we have that comes from the CovaSim. So that was the green. So you see that there is good agreement. I mean, you have to make sure you understand you cannot get hooked on the single value. Those are, it is very hard to model. There is a lot of people, like individual human behavior that comes into part. So forecasting is difficult, but however, we can see that there is very strong agreement between these two models, and then we are very comfortable using one or the other depending on the situation. Like just as a note, using the agent-based model for the travelers was difficult because to integrate them, it works well. CovaSim worked well for a constant population, etc. So we really blended those two models in order to get some simulation in the end, depending on what we were focusing on. So now that we have that framework, and we spend a lot of time actually on those models, and as here you can see that eventually we reached, like, this was until April 25, and everybody was sort of, hooray, we did really well in Hawaii, and I'll show something a little later that shows how well we did compared to other states. But so that gave us a lot of time in order to analyze those models and to play them against each other, because we didn't feel we were in the emergency anymore. However, things changed, and here is the next piece of the presentation that I want, and that is more relevant to the Delta variant. So this is the history of what happened. The orange dots here are the actual count that we took from the Department of Health website that they have for the COVID. So we were just pulling the data from there. And then you can see in blue, it's our fit. You see some of the mitigation that were done. You have like the big exponential growth in July that was suspected to be due to July 4th. And then we had a mask mandate. So we changed the transmission rate. Then we had a lockdown, the cases went down, and then we had some waves, but they were overall going down. But here you can see, and they were going down even though we had that tourist arrival was increasing, and domestic passenger count was getting close to, I believe, what we had prior to the pandemic. But tourist, like international travel is not there yet, of course. However, even though we had more people coming in, we seem to be able to control it. But if you can see, and you know that because you've been following the news, you can see that steep increase that started to happen in July. It seems that it's been due to the last 10 days or so, but it's been building up. Okay, so what you see is a buildup of a few weeks that very likely started maybe slowly back in June, and July 4 just made it explode again. So here is a little bit of information about the variant. We have, sorry, I was just looking if there was some question or, so the variance case distribution, you can see very clearly that the Delta variant has been growing slowly, like in April. In April, we had a few, and then in May, it sounded under control. The colored picture that you have here, in that picture, the brown, the dark brown here, or yeah, that brown here, is the Delta variant. And you can see, as a mathematician, we are very happy because it formed a delta shape. So we thought it was very cute, but it was taking off very slowly. And you can see that then suddenly it started like propagating. So this is what has been really hard with the pandemic, is that while things are building up, and that's part of what an exponential growth is, as it builds up, you don't see it. And then suddenly it goes really quickly. So it is very hard, it's very sensitive. And I'll show you some simulation, and you can see that I'll show you 3 scenarios. You can see at the beginning for about 2 weeks, there is pretty much no difference between those 3 scenarios. But 2 months down the line, you see a major discrepancy. And one is okay, one is not. So that's why it's very, very difficult to actually see that. So let me go a little bit to what we have here. And we are looking at the Delta variant. Okay, so this is June. We started like now, the past is the past. We're going to revisit the past in a slide a little later, but let us start in June. Okay, so that's not March 2021, that's June 2021. So again, the orange data, the orange dots are the actual count from the DOH. And then July 19, we started projecting with our model based on some assumption that the Delta variant is 50% more transmissible. We followed the vaccination rate from the DOH dashboard throughout. And then in order to make the forecasting, so again, you don't know how people are going to decide to get vaccinated. Maybe tomorrow there'll be a big rush, and then we'll have a huge increase in vaccination rate, and then those curves are going to have to be adjusted. So we made the conservative scenario that assumes that vaccination rate sort of plateaued. It did plateau, most severely on Hawaii County and Maui County, but it did started to plateau, and we were assuming that the plateau will continue. It has actually gone even lower, but that means we are in a very conservative scenario. So we assume that. We assume there was no change in current mitigation measure for forecasting. That means here we are assuming things stay the same. Mask mandates stay the same. We stay in tier 5, and there is no other changes in mitigation. And then one of the assumptions is that vaccinated people reduce transmissibility by 80%. That's quite a high number, but that's what we used because within transmissibility, we have transmission, and we have also the fact that you can get sick, not to get sick and then transmit it. They're both together in our parameter. And that reduction in severe symptom is of 95%. So here, what do we see? So we started simulating, and you can see the green line that you have here, okay, that tops at 252 cases. This is the line assuming that we are continuing vaccinating at the speed that we have done, that there is no drop in vaccination, and that will reach 65%, 70%, 80%. And then you can see we would top 252 cases on September 10 and then go down. Now you have a dark green and a light green. So the dark green is a proportion of unvaccinated people that get infected. So you can see as the number are low, then it's mostly unvaccinated people. But as we advance with that Delta variant, we can see that people that have been vaccinated are going to show infections. That doesn't mean that it's going to show into the hospital. That's the plot that we have here. You see that the green fraction gets much lower. The people in the hospital are going to be majoritarily the ones that are unvaccinated. And this is due to the severe reduction that is still sort of on the books by Pfizer. I believe the latest that I have read, it still protects against severe symptoms. So this is what we have here. And so the black dot here that you see are the numbers that we had after we started the forecasting. We have adjusted it since, but I wanted to show you a little bit what happened. We started, this picture comes from July 19, and then you can see a week of black dots. So then we have that if we were to stop at 65% vaccinated, so we can see, we assume that 65% vaccinated, that was like 2 or 3 weeks ago. We assumed it would happen earlier. We are not there. So again, we are in a very conservative scenario compared to what happened. And if we were to adjust now, that curve would go up. Then if we stop at 65%, we follow the blue line and we would reach about 700 cases in mid-November. We would not reach them because by then there will be some mitigation measure, but this is what it shows. This is the curve that we show, that we would follow. And then the orange one is smaller, and it is assuming 70% of vaccination. Okay, so you can see blue 65%, orange 70%, and then the green one 80%. So you can see between the blue and the orange, even though there is just an increase of 5% of vaccinated people, there is a huge, dramatic difference in the magnitude of where those curves would go. And also I wanted, so I'll just show you here. Here is the hospitalization that you see on that plot. So you can see the hospitalization is going to be mostly due to the unvaccinated people. I just wanted to show that, and then I can maybe do a pause and we can go to some question before I go any further. I don't know, Thomas, how you want to handle that, but let me just go through that slide. It shows that at the beginning, you can see the 3 curves are merged together. So it is really hard to see on which one you are. And this is why we have to be very cautious, because like suddenly it starts taking off. The blue curve will start take off, and at the time you see it, it's too late. So that's why I'm saying this has been building up. It does not, we're not there due to the past week or 2 weeks. We're there at least starting July 4th and probably end of June. It has been slowly building up and going up. So I don't know, Thomas, should we go to some questions or? Okay, so I'll read the question from James. Based on your prediction for 70% vaccination to directly, yeah, I do think that they are in communication with them. I'm not directly in communication with them, but it goes to the governor, I do believe. Does your model include the probability that people with cases are tested? So there is testing and contact tracing in there to some degree. Again, we're using a compartmental model, so it is hard to actually do at that granular level. Then does that probably change with time? I don't have that type of information. That's the issue. yes, we are going to adjust the model to the current vaccination rate. That has been done, but I wanted to show you a little bit where we were. All right, so now I wanted to do like look at now and look at the past. So I'm comparing the July last year, the green one, that was actually Istvan from IFA made that great comment that we're actually not just repeating what happened in July 2020, we're actually much worse. And I'm going to try to explain why we're much worse. So the green one is July last year. Okay, so we started with a smaller count. So of course we're under, but the main worry is not just that we're above. If we were above with a slower slope, that would be okay. The issue is that the slope is bigger, right? And the issue is that we have vaccinations. That means that our transmission rate is much higher than what we had back in July 2020. For our model, we had to multiply by 2 the transmission rate in order to be able to fit the current data, even though the vaccines are designed and are incorporated in the model. That means it's going much faster than it was. And here you can see we did compared with 70% vaccination. So we would go up as fast as we were basically going in July last year, even though here it assumed that we keep vaccinating. And here 65% of vaccination, which we haven't attained. Like we show that we are on a steepest increase than we were, okay? All right, so here is we are starting, I don't have all the plot as of now, but we're starting to look at the other counties. Those pictures here, this is for Honolulu County. And what you read in the newspaper, the Honolulu County number tends to dominate everything. So we really have to put a lens on the other counties, which is what we're doing, because we can see different types of behavior. We can see more alarming cases on other counties. And we were looking at Hawaii County. They have currently the highest test positivity from all counties. So again, Janet said something great. It is hard to really say why. Is it because they're testing the right people and therefore we expect them to be positive? Or is it because it's growing faster? So you can see, however, that the model, like the cases after we started projecting July 19, in Hawaii County are much bigger. So we are looking maybe at something happening there. And the spread is clearly driven by unvaccinated individual. And the Hawaii County is the county that has the lower vaccination rate. You might think they have like 56%, I think, or something versus 60%. Is it really different? It is. And as I showed you here, 5% difference in vaccination rate might result in a very different outcome. So it is very important. And Hawaii County, Maui County, they have to really try to find a way to boost their vaccination rate up. This is the comparison. So for Hawaii, they didn't have that big surge in due to July 4th. So they had a little bit, but much lower. So if we compare what's going on now to what was going on back in July 2020, Hawaii is in a different, very different trajectory that is very alarming for them. And it is alarming for them in terms of the hospital, I think. So they have to really put a lens on what is going on there and possibly come out with different mitigation measure, different restriction on different counties that might be necessary. So here, some food for thought, like are the vaccine going to be enough? Solely, that's difficult to say. What is the desired vaccine threshold? Again, that's very difficult to say because that varies with the variant. As we learn about the variant, we realize we might need more vaccination than we anticipated at the beginning. And that's why from the government, you have sometimes, okay, we're looking at 60%, but then things go for another turn with the Delta variant that maybe we didn't anticipate it as much, and 60% is actually not enough. So we have to come back and we have to adjust the message and the restriction that we are imposing. So then we heard a lot about the herd immunity, and also this is, I'd like to be very cautious. They came with numbers 70% for herd immunity, but herd immunity is a concept that works when you are in a situation with no mitigation measure, no variant changing all the time. So that concept becomes very difficult in a dynamic situation. Things are evolving extremely quickly. So we are looking at another notion, conceptual notion, which is endemic equilibrium, which is the fact that it's not either we go up or we die the disease, we kill the disease. There might be an endemic equilibrium, which means that it's possible that there is an equilibrium to be reached, which is not disease-free, but which is disease controllable. Okay, where people might get sick. This is sort of what we have with the flu or with the influenza. We're not able to completely kill influenza. However, we are trying to control it with vaccine and then medication and other means. So we are looking at endemic equilibrium. And I think people need to really understand this is on optimal control problems. You have a dynamic with a lot of players into the picture, the humans, the disease, and then you have some control, which is behavior, mitigation measure, vaccine, and others. And then you have to balance them and play them against each other. So it is really trying to optimize that. It's not clear what is the criterion to optimize. Is it the number of daily cases that we have, the number of hospitalization? And so it is a very complex problem to actually formulate, but there is no doubt that we have a natural dynamic that we don't control that well, especially in the future, because it's people driven. And then we have some controls that we can use in order to optimize the outcome. So then other little food for thought, like there is recent data that suggested that, okay, so this we did, unvaccinated people. I wanted to make sure this is a very important message. We have a population, fraction of the population that do not have access to the vaccine. Those are young children, 11 and younger. Those are people with immune disease, or there are people that have reaction to vaccine, that cannot get vaccinated. So the unvaccinated people are putting those at risk. Then we have a big question mark. Is vaccine efficacy declining after a few months? It seems that it's going to be the case. And therefore, we're hitting the mark of 8 months when the first people were vaccinated in Hawaii, and we vaccinated first the very vulnerable population. So what is going to happen? That population will need a potential booster, a third dose. The elderly, is it like we already gave them 2 doses? Is it a third dose? Is it safe? Has it been studied what a third dose would do to that population? They are going to come first in line, again, if we are not able to control those variants and the vaccine are not high enough so that we are in a safe spot for this. And then we have another control, which is the Aloha Safe app. And I think this is contact tracing. That this can be very robust, and it can really help in order to target in a very targeted way to find and to control a little bit the spread of the virus, right? So vaccination plus Aloha Safe app, I think right now they're the most powerful tools that we have in order to address the current alarming situation. Are this the solution? That's unclear, but they are definitely what we should use now. Everybody should have the Aloha Safe app on their phone that is activated, and everybody that can get vaccinated should get vaccinated. You do not get vaccinated just for you. Not enough vaccination, it might have consequences way beyond yourself. It might have, as I said, it might have consequences on people that cannot get vaccinated. Other consequences might be economical, like pretty impactful if we have to reverse some intervention. Okay, if we have to go back to tier 4 or tier 3, or if you have to go into a new lockdown, we might have to reverse mask mandate and then ask for everybody, even outside, to wear mask mandate. So it goes way, way beyond what we might think. Then I will go into one more slide. I have a few more, but then I want to open for discussion if people want to talk a little bit and ask question and give their opinion as well, because again, this is mathematics, and I said that the other day, mathematics does not lie. However, it does not know. It does not know how people are going to behave. It does not know how mitigation measures are going to change. So everything that I presented tonight might need to complete adjustment in a few days from now, and we are doing them. So I wanted to show just something that we realized. This is death. This is comparison for death count, annual death in the different states. And you can see that this is the changes in death from 2017 to 2018. It's the gray little bar. From 2018 to 2019, it's the orange one, and from 2019 to 2020, it's the blue one. So Hawaii was very different. It's an outsider compared to basically every other state. There was just the same increase of 2% over the last 3 years in terms of death. Okay, so we're trying to understand why. What did that happen? And this is a relative increase. So we cannot say, oh, we had low numbers of COVID, and therefore we had less death. Yeah, but it's relative. So it still should show that there was an increase in death that was unusual compared to the year before. Then we show some other states like Montana, from 2017 to 2018, death decreased, but then they had a big increase. And then during COVID, a large increase. Wyoming did the other things. 2 years ago, they had a big increase, a decrease, and then a large increase. And New York City, of course, they had a large increase. And here you can see sort of the number of deaths per 100,000 people. So we're trying to understand that. One thing that has been thrown out is the fact that we in the state, I do believe we have a very large influenza death count. So we killed the flu with COVID. COVID didn't kill the flu. The mitigation measure actually killed the flu that we had to take, the mask. So the flu death count in 2020 went down, and the COVID, but however, COVID didn't go as high as the flu death count. So we're not sure what happened. It seems that there are maybe some other death, or there is something else that happened in Hawaii. The one thing that we've noticed, and I'll finish with that, is it's the fact, and I'll show this on this graph. Let's see where it is. It's this one is heart disease. Peaked much higher in 2020. It peaked just before COVID, before the first cases of COVID that we had. Is there a correlation there? I have no idea. It's just a fact that came, again, mathematics, that just what it saw, that just what it says. There was, and that's very unusual compared to other states. So we are also trying with the team, we're also trying to look at signs pre-COVID, things that were different compared to the years before that could have hinted that something was coming on and that it was already there. So that's other stuff that we are looking at. And this was definitely very unusual. You can see 2018 heart disease and 2019, they were superposed during the winter, and 2020 completely different, which resulted in those bar graph that were here, very different. So I think that was a lot maybe of information, and I'm going to stop there and be happy to take questions that I can answer. I know there are other people that are probably better qualified than me to answer a lot of the questions that you might have.
Thank you so much, Monique. As always, learned a lot and definitely contribute. And if you want to see her, she'll be on KHON News this evening talking about the work she just presented to everybody here. So let's see. I don't see any. Let's see if you answered any think all the questions have been answered. Let's see from the panel questions. Based on projections for 70% vaccination rate, has HiPAM communicated these results directly to the governor, who plans to remove all restrictions upon 70%?
Yes, they were. And that's what Victoria told me. And she believed that even some of the mask mandate were not lifted due to those projections.
Awesome. And then another question. I think it was, what about pneumonia? I'm assuming that that's another variable that's of interest. You focus on heart disease, Monique, but
yeah, pneumonia. Yeah, we're struggling gathering data. And this is it's hard to get the data and to get them at that granular level, because for Hawaii, a lot of data are under 10, the count. And then they don't give you the count. You just know it's between 0 and 9, and you don't know exactly where. And we've been trying to find data to separate influenza and pneumonia, but it's hard. We're having a little bit of a hard time with that.
Perfect. I don't see any other questions. Let's see. Let me just make sure I didn't miss anything. But Monique, thank you so much for taking the time and for the work of you and your team to share with everybody present. I see Alice is on, and I know Alice is provided a lot of support.
Yeah, thanks, Alice. It's been a blessing to work with her. She's been so helping at the computational aspect. And then there is also Dr. Milaiko from the math department with the conceptual and everything, actually. And those plots were created by our students. So really kudos for them. They've been working around the clock, but they found themselves in a very exciting position to make math visible and to have people look at the work. So that's really exciting.
Awesome. Well, thank you everybody for taking time out. I know days are always busy, weeks are always busy, and we hope that you learned a bunch of things from Dr. Shiba and a little bit from our science highlights. I know our original members are used to a weekly rhythm, but I think right now we're all rowing pretty hard in terms of our efforts. So stay tuned. I think we're gonna make it a little, probably once a month, unless there's anything major that comes about. So we'll work internally within our core members to see if, based on what's happening in the state, if we need to adjust the frequency of these Thursday meetings to make sure that everybody stays well informed. But stay tuned for your emails. Thank you again for attending, everybody, and have a great rest of your afternoon, and have a great great weekend, and just stay safe and mask up when you're with a lot of people. I think that's just the best advice we can give to everybody.
Thank you, Thomas.
Thank you, everybody. Aloha.